Sir, please start.
Yes. Good evening, everyone. I am Dr. Pranuti Jadhav, and on behalf of MahaIP 2025 team, I welcome you all to the second episode of Vaccine Samvad, a platform dedicated to spreading information and awareness regarding vaccines by the stalwarts in the field of vaccinology. To go ahead with it, I now welcome Dr. Sanjay Pakmode sir, President MahaIP 2025, and request sir to kindly speak a few words.
Namaskar. Respected Dr. Nitin Shah sir, Dr. Digan Shastri sir, Dr. Sanjay Marathi sir, Dr. Sadachar Uzlambekar sir, and our Dynamic Secretary Dr. Amul Pawar, and Abba Sononi, and all the MahaIP office bearers and all the faculty, all the members who have joined for the today's webinar on the Vaccine Samvad. I welcome you all. This is a very highlighted show of every month, that is a Vaccine Samvad, and this is scheduled on the first Friday of every month. Last month we had a BCG vaccine, and it was a very successful Vaccine Samvad that time, and this is again, this is the second episode, and it is going to be again a blockbuster this time also. Now, we know in the vaccines everything is changing. New information comes, newer studies come, newer vaccines are schedules. But about today's vaccine, this vaccine is a game changer vaccine. People in the past used to talk nonsense about so many vaccines, but after HPV vaccine, I think the COVID vaccine, they have changed their minds. They have changed their statement what the COVID vaccine had done. And this second vaccine is the HPV vaccine, with the vaccine which is talked by every person. That means in the medical fraternity, right from the pediatrician to physician to gynecologist to obstetricians, and up to the government ministers also, with the vaccine which is talked on in the budget also. So this is such an important vaccine, such a game changer vaccine, which has changed the perspective of the patients who are the recipients of the vaccines. And I think this will definitely going to change in future how the vaccine was how vaccine is important. And the vaccine which is preventing the cervical cancer, which is the second most common cancer in India. So definitely, because of the long period of in the cervical carcinoma, the long period in the development of the cervical carcinoma, and this vaccine appears to be a very promising vaccine. So with this short remark, I hand over the mic to Pranuti, and you can move ahead with your next.
Thank you so much, Pakmode sir. I now welcome Dr. Amol Pawar sir, Secretary MahaIP, and request him to kindly address the delegates.
Thank you, Dr. Pranati. First of all, I welcome the most popular vice president, past president of Central IIP, Dr. Digan Shastri sir, to Maharashtra IIP platform. Then our president of president, Dr. Nitin Shah sir. Then today's one of the panelists, senior pediatrician and vaccine expert, Dr. Sanjay Marathi sir, and our own past president, past secretary of Maharashtra IIP, Dr. Sadachar Uzlambekar sir, from my own city, Nasik. So we welcome all of you to Maharashtra IIP platform, and also thankful for consenting to be there for this session. I also welcome our president, Dr. Sanjay Pakmode sir, Dr. Meena Sheikh sir, Dr. Ravindra Sonone sir, treasurer, Dr. Sanjay Deshmukh sir, editor, Dr. Pranuti Jadhav, and all the attendees who have joined on Zoom platform as well as YouTube platform. This is very nice initiative taken up by none other than Vaccine Shah, Dr. Nitin Shah sir, and it's very popular series across all zones. So as you all know already, Sanjay Pakmode sir has told globally, when I have seen the data literature, almost 6 lakhs women and almost 60,000 men, they were the sufferers of HPV related cancers. And also our government is also trying to push this vaccine in government setup, PSC level, and also many of the in last 2 to 3 years, also many of the NGOs like Rotary, they are doing these camps for many of the adolescent girls, so that this burden will come down. So we will get lot of learning from all these experts today. So over to you now, Pranati Jadhav madam, for further proceedings. Thank you.
Thank you so much, Amol Pahar, sir. Now I request Dr. Sanjay Deshmukh, sir, convener Maha IP, to kindly address the delegates.
Good evening, all my happy respected members. First of all, my heartiest wishes for all my happy members on occasion of World Women's Day. And I think today's topic is related to the all the women. And unfortunately, what I think HPV is the vaccine is one of the most important vaccine, but the most neglected vaccine. And we thanks our Maha scientific team, our Mahaguru, Dr. Nitin Shah sir, who initiated this Vaccine Samvad on Mahapi platform. And today we have experts like Dr. Digan Shashit sir, who was the ex-member of ACIP committee, our own dynamic Dr. Marathe sir, and past secretary Dr. Sadachar. So I hope this vaccine journey will continue to update us and make awareness in all the Mahapi members uh, to increase the knowledge on the vaccines. So thank you and best wishes.
Thank you so much, Sanjay, sir. Now I request Dr. Minaz Sheikh, sir, Scientific Chairman Maha IP, to introduce and invite our speakers for today's session. Speakers and panelists.
Uh, Thank you, Dr. Pranuti. Welcome back, each one, for the session 2 Mahasamvad Maharashtra IP. I've been assigned to introduce our experts, which actually does not need any introduction. But then I have to. So let me introduce Dr. Digan Shastri, sir, who has been senior pediatrician from Surat. He has been ex-president Indian Academy of Pediatric 2019. He has been convener ACVIP IP 2024-25. Member IPS Program Area on Immunization 2023-25, Chairman IPNCCD Project 21-23, ex-member Standing Committee International Pediatric Association 2019-21. He has plenty of publications to his credit, including index journal articles, chapters in book, and he has been editor to the IP textbook of infectious disease, IP textbook on vaccine, guidebook on immunization, and FAQ and rational antibiotics. He does not need any introduction. However, this is the brief of his CV. Welcome, sir, for this session. Our next expert is our own, the handsome, dynamic Dr. Sanjay Marathe. He's a senior pediatrician consultant at Nagpur. He has been ACVIP Best Zone member to 2022, Pedicon 2018 Organizing Secretary, and directors Marathi Children's Hospital and Color Hospital in Nagpur, President Maharashtra NNF 2009-11, President IP way back 2005, and he has been the guest speakers and acknowledged expert in the field of vaccinology. Our next faculty is Dr. Sadachar, who is from Nasik. He is the director of Aditya Children's Hospital, Nasik, Director Chiranjeev Children's Hospital, Nasik, and is attached to Government General Hospital, Nasik. He has been secretary to NNF, treasurer to IIP Maharashtra, secretary to IIP Maharashtra. He has been the chairman, Scientific Committee, National Decon 2024, and he is acknowledged trainer for various CIP module, and he is also a budding vaccine expert in days to come. So welcome you, Sadachar, welcome Marathe sir, and welcome again, Dr. Digant Shastri sir. So with this, back to Pranati. Pranati, are you there? Okay. If Pranati is like, we will start. Over to Nitin Shah sir for the
Yes.
proceeding.
So good evening, the office bearers and the dignitaries who are present here. Good evening to all my faculty, especially Diganbhai, the convener of the current IAPSC VIP, and I think that's a very important task that he's doing. We have Dr. Marathe, who is the master of HPV vaccine besides all other vaccines, and we have Dr. Sadachar, who is an adolescent specialist and HPV vaccine being given in the adolescent. I thought this is the right team with whom I can discuss about HPV vaccine. India contributes to almost 120,000 of the 600,000 cases of cervical cancer that happen in the world. And unfortunately, in spite of our best efforts, almost 50% of these women die, especially in the developing part of the world where the treatment not be easily available. So India contributes to almost 77,000 of the 341,000 deaths that have happened. Now, if you look at this, that means we are contributing to 25% of morbidity and mortality, even when only 1 out of 6 women in the world is Indian. So, which means our women are having more incidence of cervical cancer than what should happen just based on the population itself. And that stands out when you look at the age-adjusted incidence rate of CS cervix in women. It is 18 per 100,000 compared to the world's average of 13.3 per 100,000. So that is an eye opener that we are having more disease. Maybe because of the genital hygiene, maybe because of various other reasons, malnutrition, HIV, other STDs, and so on and so forth. Now, if you look at not only the CS cervix, but now this is a gender neutral vaccine. So we also have other cancers in the women, which are like the vulval, vaginal, anal cancer, and the head, face, neck cancer, which could be anywhere up to 1 to 2.5 per 100,000 population. And not to forget males who can have a penile cancer, anal cancer, beside the warts in both the sexes and the head face, neck cancer, which almost takes care of 2.7 to 5 per 100,000. So there is a beyond CS cervix, this vaccine has a lot of advantage. And as Dr. Sanjay Pakmore said, this is the second commonest cause of cancer in women after breast cancer. And unfortunately for breast cancer, we don't have vaccine, but for HPV, we have a very, very strong vaccine. And that's why it remains the top of the top of the line vaccine, which, as someone said, is grossly underutilized. And I think we will impress upon all the our colleagues who have joined to listen as to why this vaccine is so important. As Dr. Sanjay said, now that we have a cost-effective vaccine from India alone. So the flow will be that we will have Dr. Digant Shastri presenting the disease burden for the first 8 to 10 minutes. And after that, we will have question answer with Dr. Digant, Dr. Marathe, and Dr. Sadachar. So over to you, Dr. Digant Bhai. Please share your slides and start your presentation.
Visible? Slides are visible?
Yeah.
Okay.
Make it full screen, sir.
Yeah,
Yes,
I have made it full screen.
yeah, it is there.
Yes, sir. Yeah.
Go ahead. Go ahead.
So, good evening, friends. It's a pleasure coming to the event organized by Maha IAP, and particularly, it's a pleasure for me to be on a panel with Dr. Nitin Bhai. I have a memory of my first debut on national platform in 2003 in Calcutta, where in the immunization panel, I had opportunity to share the stage with Nitin Bhai. And at the end of the session, Nitin Bhai gave me a pat on my back, said, Digan Bhai, barabar pad ke aaye ho. I still remember, Nitin Bhai, your words. And so over the period, there were many occasions where I had a learning opportunity while on the dais with him. And so once again, I thank the Maha IAP team, President Dr. Sanjay, Secretary Dr. Amol, Scientific Convener Dr. Mihaj, and Dr. Sanjay Deshmukh for giving me this opportunity, as well as my mentor and guru, Dr. Nitin Bhai. It will be a great learning session for me also. So I was instructed that because we will be discussing about the different aspects of the vaccine. So before we discuss about the vaccine, I have to establish the importance of that vaccine by giving you some highlight about the human papilloma virus infection. So very quickly in 7 to 8 minutes time, I will try to take you through some important aspects. As we all know that the HPV is one of the most commonly transmitted viral infection of the reproductive tract. And most of the women and male who are sexually active, they will develop HPV infection sometime in their life. But fortunately, 90% of them, they get cleared of this infection. And then there are few who have got infected with the oncogenic type, and this infection persist. In that case, they may go for a development of the cancer. So the culprit is human papilloma virus. I am not going into the details of the virology, but there are, if you see the structure of the virus, it has got two proteins, that capsid protein L1 and capsid protein L2, out of which the capsid protein L1 is responsible for the uh, changes in the epithelium, the cancerous changes in the epithelium, as well as this capsid protein L1 is important from the angle of production of the vaccines for the human papilloma virus. There are almost 200 serotypes, but out of which fortunately only 15-20 serotypes are oncogenic. And out of this again, the serotype 16 and 18, they cause almost 70% of the invasive cervical cancer disease all across the globe. So naturally, we need to have the vaccine for uh, serotypes covering this. Again, then these serotypes are divided into the high-risk HPV serotypes and low-risk HPV serotypes. Now, the high-risk serotypes, they lead to high or low-grade lesions of the genital tracts, cervical, anal, vaginal, and vulvar cancers. While the low-risk HPV types, they are like 16, 11, and then many others, they lead to low-grade lesions of the genital tracts, anogenital warts, as well as respiratory papillomatosis. So this is about the pathology. If you see the burden, global burden, almost 100% of the cervical cancer cases across the globe, they are related to the HPV infection. 88% of the anal cancers, 70% of the vaginal cancers. So definitely it is an important etiology from the angle of positive etiology as a cancer. But it is not just cancer, it is much more than the anogenital cancer, because the HPV infection can cause, apart from the cancer, it can cause precancerous lesions like VIN, CIN, AIN, as well as it can cause the anogenital warts also. As a pediatrician, we don't see cases of anogenital warts, but if we just quickly review about the warts, the estimated incidence, again, this is a US data, not from our country, it is about 1 to 5%. And in US, the statistic says that it is at a younger age in the women compared to the male. Most of the time, these anogenital warts are due to serotypes 6 and 11. At times, other serotypes are found, but again, they are mostly as a co-infection with either 6 or 11. So from the anogenital wart angle, serotype 6 and 11 are the important two serotypes. The disease burden, already Dr. Nitin Shah sir has already highlighted these points, that almost every year 100,000 plus cervical cancer cases, 5,000 plus anal cancers and vaginal cancer cases, and 3,000 plus oral cancers are due to HPV. And the one point which he highlighted, again, I also want to highlight that compared to the global ASR, that is 13.3 per 100,000 population, In Indian women, it is 18 per 100,000 population. So the Indian women are at a more risk of getting the HPV related cancers. Again, this data already, Dr. Nitin Bhai has already presented more than 600,000 cases and 77,000 deaths. So these are really alarming figures, and we need to act fast to prevent. And this disease deaths can be easily prevented by effective vaccination. So definitely there should be change in the immunization policies, as well as both in the public sector as well as private sector, and that we will be discussing in the next part of the symposium. Just a quick review about the serotypes prevalent in our country. So in high-risk HPV types are found in almost 97% of cervical cancers. And again, if you count the HPV 16 and HPV 18, totally they count around 83% of the invasive cervical cancer cases are due to HPV 16 and HPV 18. The HPV 16 or 18, they are accountable for high-grade lesions in about 62%, 28% in the low-grade lesions, and 5% of the women with normal cytology, they also may have a HPV 16 or 18. So definitely this is a matter to be kept in mind. Now, prevention, we definitely have a long discussion in the next part. But for the prevention, the vaccine is not the one strategy. Vaccine definitely is a primary strategy. And here you have the HPV vaccination, particularly for the adolescent girls. The vaccine definitely is can be used in the older women also, but earlier you administer, the vaccine will have a better immunogenicity and better effectiveness. So primary strategy for the prevention is vaccination. At the same time, there is a secondary preventive strategy. And again, it has got two pillars, that is a screening as well as treating the precancerous lesions. Now, when we talk about the screening, I have seen that, and there are studies also that even amongst the doctors also, there is very less awareness about the cervical screening. So what WHO says that any woman who is of the after the age of 30 should get screened for the cervical cancer every 5 to 10 years. But if the woman is suffering from HIV, in that case, the age for starting the first screening is at earlier age, that is 25 years age, and it has to be done at every 3 years. While any woman in her lifetime should be screened with a high performance HPV test at two milestones, that is at 35 years of age and 45 years of age. These are the screening protocols suggested by WHO. And as I told you, unfortunately, not just the common people, but even our medical people are also not much aware, or the compliance to the screening is very, very less amongst our medical professionals also. And that is why the WHO has come out with a target of 90, 70, 90 by 2030, where the 90% of the girls should be vaccinated with HPV, fully vaccinated with HPV by 15 years of age. 70% of the women should be screened with high performance test at 30 years, 35 years and 45 years age. And 90% of the women who are identified by test as a cervical disease should receive the treatment. So this strategy 90, 70, 90, that is a WHO's goal. And when we talk about this, as in the beginning someone told, we usually talk about the cervical cancer or vulvar-vaginal cancers, and the males are overlooked. But then there is a study, this HIM study, which was performed in Mexico, Brazil, and United States, and they found that the prevalence of HPV infection in male between 18 to 70 years, it is almost in all the age group, the infection is seen, and with the peaking at the age of 30 to 34 years. So definitely the vaccine is not just for the woman, definitely, because there is a high mortality in women. That's why we are targeting it as a cervical cancer vaccine. But this vaccine definitely have a role for the males also. And friends, just recently on the 4th March, there was a HPV awareness day. And I think in that context, this session organized by MahaEAP with our great guru, Dr. Nitin Shah, I am sure that will be contributing in creating more awareness about the vaccine amongst our pediatrician colleagues. Thank you so much.
Thank you, Digant bhai. You can stop sharing your. Yeah, all right. So I think we will start with the question answer, and I will start with Dr. Digant first. And you already covered though, but just to recapitulate that, what percentage of oncogenic HPV are covered by 4-valent vaccine and the 9-valent vaccine
So basically,
in internationally and in India?
no, so basically, when we talk about the coverage by the vaccine, so we need to know about what are the serotypes covered in that particular vaccine, as well
Correct.
as what are the serotypes which are high risk oncogenic serotypes. So if you see the high risk oncogenic serotypes, they are 16, 18, 31, 33, 35, 39, 45, 51, 52. So these again 16 and 18 are the highest causing serotypes.
No, so my
Now,
specific question is that 4-valent vaccine will cover
yeah, yeah,
what
yeah.
percent of cervical cancer and 9-valent? Because that's
So
a question. Why we should use 9-valent when it's so
yeah,
expensive?
so again, so that's why I'm coming to the answers. That if you see this 4-valent vaccine, it has got the 4 serotypes: 6, 11, 16, and 18. So 6, 11, 16, and 18. So you have only the 2 serotypes which are causing, means which are high oncogenic, 16 and 18, that is covered by 4-valent. Both the brands, the Gardasil as well as the Cervavac. While the HPV-9, you have, apart from that, you have 6, 11, 31, 33, 45, 52, 58. So you have 7 oncogenic strains which are covered in HPV-9. So out of 12 or 15 oncogenic strains, you have almost 7. So you can say that up to the tune of 60% coverage with the HPV-9, while for the HPV-4, the coverage is up to 16, 17%. But
Okay,
the
so
two main causative serotypes, they are covered with all the 3 available vaccines, that is 16 and 18.
correct. So just to recapitulate, the HPV-4 has 2 oncogenic viruses, 16, 18, which globally will cover 71% of cervical cancer, whereas 83% in India. And when you add 5 more in HPV-9, it will cover 82 to 83% of the cervical cancer causing HPV globally and 98% in India. So when it comes to CS cervix, obviously 9-valent vaccine is virtually covering almost every oncogenic type. All the vaccines have 16, 18 for benign warts, which covers around 90, because all 90% of benign warts are because of the 16 and 18. They are well covered by the vaccine. Now the confusion, Dr. Sanjay, this 4-valent vaccine and 9-valent vaccine have a different age limit and different what do you call sex indication, male versus female, or for both the sexes. I mean, what is the confusion? Internationally, what is it, and India, what is it? In brief, you can say.
Yeah, thank you for the opportunity, and I'm honored to be a part with Dr. Nitin Shah is there as a moderator. This confusion should be resolved very clearly because this confusion persists with so many people.
Correct.
Because there are different age recommendations in India and different age recommendations in the world.
So let's go one by one. Sanjay,
Yeah.
I'll ask you HPV-4, whether it is MSD or whether it is so first MSD indicated in male and female both or only females?
In India, it is only indicated in females.
And internationally?
Internationally, it is recommended as a gender-neutral vaccine, can be used in boys as well as girls.
Correct. And age indication in India and abroad?
In India, you can use it from 9 years of age up to 27, can be extended up to 45.
45.
Whereas in internationally, again, it is indicated in the
Same age group.
9 to 27 can be extended up to 40.
All right. Now let's take HPV 9. In India, it is licensed for.
Yeah, India, it is a gender neutral vaccine.
Correct.
In the boys can be given from 9 years to 14 years.
14 years.
Okay.
And in females, it should be given from 9 to 26 years with a different schedule.
And internationally?
Internationally, it is the same like quadrivalent HPV Gardasil can be given from 9 years up to 27, can be extended up to 45 as an
in
STD.
both the sexes.
Yeah, in both the sexes.
And coming to Sarvavac, it's of course licensed only in India. There is no international recommendation. So WHO does recommend.
It is our own vaccine by Serum Institute.
So what is for which sexes and what age? Gender neutral. Okay.
Gender neutral vaccine.
Okay.
In boys can be given from 9 to 26 years. In girls can also be given from 9 to 26 years at present.
Okay. Okay. So please keep it a point that these different schedules and different indications are specific to India. Internationally, they are all recommended till 45 years of age. And that's because in India now, the Drug Control General of India insists on a trial for the indication that you want. So you want indication up to 45, you have to do a trial up to 45 years of age. And just because it's internationally licensed till 45, they will not automatically give you a license. Because these vaccines have done trials accordingly, they have got, like HPV4 has no male trial in India, so no male indication was given. HPV9 and Sarvavac both have trial in male, so they have been given, but in the age group where their vaccines were tried. So just be careful when you use these vaccines that they are not interchangeable from that point of view because the age indication are different. Now the schedule, Dr. Sadachar, the schedule for 9 to 14, schedule for above 14. So let's take again first HPV4. Only in females in India, what will be the schedule?
For HPV4, for females, the schedule will be from 0, 2 months and 6 months.
No, I'm saying 9 to 14 years.
9 to 14 years, 2 doses.
2 doses.
0 and 6 months.
6 months apart. And both for males and females the same.
In India, it is not.
No, I'm talking about the HPV4 of serum, which also is gender neutral.
Both were same.
Both okay. And for HPV9 in India?
HPV9 in India is for 0 to from 9 to 14 years, 2 doses, 0 and 6 months. And for 15 to 26 years, it is 0, 2 and 6 months.
That's for females. That's for males, it's not indicated beyond 14 years, so it's only 2 doses.
Yes,
but the DCGI, the licensing is for only 3 doses, 0, 2 and 6 months. It's only the IAP, SCVAP which has said that you can use it as 2 doses. So what is this confusion, Dr. Sadachar?
Basically, there are recent studies are not there basically regarding the trials in males basically. Correct. So for that there is a disparity.
Correct. So I think again to make it clarify that HPV4 is only for females in India, not for males, and it is 9 to 14 is 2 doses, 6 months apart. Above that, 3 doses, 0 to 6. HPV9 of MSD is only both for males and females, but different age group. For males, it is 9 to 14 years. 14. And for female, it is 9 to 26 years. Now, for males, when you use in India, the indication, the HPV9 licensing is only for 3 doses at whatever age, 0 to 6. But ACVIP has very correctly taken the standard. You can use for 9 to 14 years, boys and girls, HPV9 is 2 doses as 0 and 6 months, and above 14 years for females up to 26, you can use 3 doses, 0, 2, and 6 months. And I'll come to the reduced dose schedule indication discussion later. Another thing, Dr. Sadachar, that many times the parents ask, 9-year-old, she's not sexually active. Now you're talking about cervical cancer, 14 years, 30 years, 40 years. Will it last the protection for so long? Will I need a booster later?
Yeah, there is no need of booster. And other thing is that vaccination so early is very important because that increases the chances of completing the series of doses.
Correct.
Another thing is that earlier we vaccinate in adolescents, there is an increased amount, this immune response high. Yes. And correct. I need to give some more points regarding that. That there is a cost saving also when there are 2 doses when given earlier.
Correct.
Other thing is that we can combine it with Tdap at 10 years. So that it is whole vaccination thing is covered. and as there are no boosters.
So compliance will be better.
Effective, and there is a nice robust immune response as early as you start. And there is definite studies that whenever we do a little early, meaning 9 years we start, there is a more than 80% reduction in the disease burden. And when it is latter, the disease burden reduction is less.
Correct. So I think important is that you can never judge when will be the sexual debut in a given person. If you wait and the debut happens, then you know your chances of acquiring an HPV infection is highest in the first few years after sexual debut. And if suppose someone has already had a infection with one of the oncogenic virus, then the vaccine is not therapeutic, so it will not work. So it is not to be presumed as to when will someone become sexually active. And because of the robust immunity at young age, giving 2 doses only, amalgamating with the childhood vaccination program, as Dr. Sadacha said, all the advantages, and then now studies have proved very long-term data that the vaccines given at such a young age also works for 10, 14 years. And to me, any vaccine which works for 10 years is almost like a lifelong vaccine. Okay, now let's discuss specific vaccine.
Just one point.
Yes, Sanjay.
Yeah, in an immunocompromised patient, the schedule remains 3 doses, not 2 doses.
So we'll come to that a little later. Anyway, you answered that question. That's good. So now we don't have the bivalent vaccine from GSK available anymore, but because it had didn't have the benign ward 6 and 11, only at 16 and 18. So obviously with the higher valency vaccine now being available and becoming a norm, that vaccine has been at least withdrawn from our country, and I'm sure gradually it will be withdrawn from the world. So we will only discuss the HPV from MSD, HPV-9 from MSD, and the HPV from serum as the 3 vaccines available for our day-to-day use. And let's take some rapid fire. So first, Dr. Digan, can it be used for someone who had past HPV infection, or even say past treatment like a cervical excision done or a cryo done? Will it be helpful, and how?
Definitely, because see, we know that there are several oncogenic serotypes, as well as there are low risk serotypes which can cause the warts and other infections. So suppose a patient has a infection with HPV type, say 16, but she is not having immunity against the other serotypes. So when we offer the vaccine, she will be having additional immunity against the serotypes which she has already not got infected.
Correct.
So for that reason, irrespective whether the person has been infected or the person has been treated for the cancer, they should be offered with the vaccine. And again, knowing the serotype is not that easy job. So unless until you are working in a higher centers where you have the cervical sample serotype testing is done, in that case only you will be able to know that the person is infected with type X or type Y serotype. So it is
that's
always,
not even required to do.
Yeah, not required. It is not cost effective also.
Absolutely. So I think very rightly said that, if you look at the pivotal trial done with HPV-4, only 1 to 1.2% of the subjects were enrolled between 16 to 24 years, women, were actually seropositive for all the 4 types which were there in the vaccine, which means 98 to 99% were not. So even if 24% of these subjects were positive for one of the 4 viruses, but they will still be protected for the remaining 75% of the viruses which they have not got. That's number 1. Number 2, reinfections are known. The same virus can reinfect you. First time you may be lucky to recover on your own. The second time you may go into a precancerous lesion. And the third is, even when you're treated with a cervical lesion like cryo or whatever, still there are chances of reinfection. And these all studies have been done in such subjects and shown the efficacy may not be as good as 100% like you do in a naive person, but it's still very high. So one must use it. Absolutely no problem. Okay.
Yeah. Along with that, Nitin bhai, just one word of caution we have to tell to the patient that when we are advising them for the vaccination, naturally the first question patient may ask that when I am infected, will this vaccine work or not.
Correct.
So definitely it will work for the others,
Yes,
other
not for the
infections
same.
as well as the subsequent infections.
And that is the reason why
Yeah.
Pap smear program has to continue.
Yeah. So that should be continued. And by chance, if the person is undergoing some treatment for the cervical lesion, so that also should continue. It should
Correct.
not, patient should not take it granted that now there is no need for these two
Correct.
interventions.
Okay, Dr. Sadachar, how important are the benign warts and why prevent them?
Definitely, sir. These are external genital lesions, what we say, of HPV disease. They are mainly of two types: Chondroma acuminata, we call as genital warts, and
Correct.
other is the penile intraepithelial neoplasia. This is believed to be a precursor of penile cancer.
So I'm talking about only the benign warts.
Yeah, benign warts are basically, they are HP type 6 and 11 that cause them, and they are commonly treated types of in males and females both. The quadrivalent vaccine containing the most common HPV types that we found may have effect to prevent these warts. And why prevent them? Because they have a potential to grow into the cancerous lesions after that. So we need to prevent them with the effective vaccines.
Okay, fine. So up
And
to
along
1%.
with that, I think one more is about the cosmetic angle also. This warts will have a, can have a patient may have a cosmetic angle as well as can have a mental issues also due to disfiguration and all these things.
So someone asked in the chat box, is there any data on warts in from India? So there was a multi-study study done of skin doctors, general practitioners, neurosurgeons, and dermatologists, and they found that 1 to 1.5% of the the general OPD patients were actually for benign warts, and when it came to dermatologists or the gynecologists, it was even more because of the bias. And as Dr. Digan Shastri said, that the major trauma was that you have an HPV benign ward is a trauma, mental trauma, and that's the reason why. Besides the physical disability that can lead to, so they are as important as the cancer. Though we get worried about cancer, we should also worry about the external genital lesions. All right, Dr. Sanjay. Now the big question: what is the long-term efficacy of this vaccine? I'm talking about HPV-4. MSD is HPV-4.
See the long-term efficacy trials. If you see the vaccine efficacy trial that was Future 2, was got the extension, and now we have a 14 years data available.
Yes, 14.
14, 14 years data, and the study which was done in 4 Nordic countries, Denmark, Sweden, Iceland, and Norway. The vaccine efficacy started from 2004 to 2007. And 2007 they continued the follow-up, and initially every 6 months, then at 2 years, 4 years, 6 years, like that.
So it was an open label in the later
it's an
part.
open label, and they used to take a tissue sample.
Correct.
And in this tissue sample, they used to take 2 different sites, one from the ectocervix and the endocervix, and another saw from the perianal region and the other vulval and vaginal.
Correct.
And they will see if there is any HPV
persistent infection.
HPV infection. Then they will go for HPV DNA, and they will go for the high risk intraepithelial lesion of cervix and other things.
Correct. That's the standard of testing when you do Pap smear program.
And for immunogenicity, they have taken antibody titers only at 9 years and 14 years.
Yeah. So what was the efficacy at the end of 14 years?
Efficacy, not a single case has been identified for high risk genital lesion. And
so which means the efficacy of 97 or 98%, which was there in a double-blind randomized control trial for the first 4 years at the end of the study, after that they did not see any single breakthrough case.
And additionally,
so that means effectiveness was nearly 100% for 14
almost
years.
100%. And as far as the antibody titers are concerned, the seroconversion is almost 90% even at 14 years of age.
Correct.
That means there is no immunity winning.
Correct.
And at present also there is no need of a booster to be given in this patient.
Correct. So actually, if you look at the antibody levels which are done serially, that's true for most of the vaccine. In fact, there is a very high titer immediately 1 month after the last dose. Then there's a rapid drop by 1.5 years, and then there's a plateau, and that continues for years. And that's what Dr. Sanjay was talking to, the plateau. 95% plus people who were originally given the vaccine 14 years back were still seropositive. And though we don't have a serological correlate of protection, so we don't know, but still, the fact that there was not a single breakthrough case itself tells you that it was fantastic. And just to talk about the serological correlate of protection, if you look at the HPV4 MSDs type 18, there was a massive drop in the antibody at 18 months. In fact, 35% became seronegative, and the titers dropped to almost baseline. And yet, 14 years, no single breakthrough of 18. That may be, we really don't know antibodies, what works, but we know that it works for very well. All right. So now let's, yes.
Additionally, very interesting, another studies which I have seen. There is one study from India called as Sikkim study.
Correct.
The Sikkim study is also for 10 years. And so at the same finding that even for 10 years in India, there is not a single case identified.
Absolutely.
And another long-term study was seen in the elderly women from 26 years to 45 years.
That is Future 3.
That was Future 3 from 7 countries.
Colombia, and that is 10-year long-term data, suggesting the same thing.
There is lot of inference with this long-term follow-up study that this vaccine can be used without a booster.
I think that's a very important statement Dr. Sanjay makes, that there is at present no data to suggest that you need a booster dose, and probably these are like lifetime working vaccine. And when we come to reduced dose, you'll be even surprised more. As such, we are giving more doses than what is required. All right, Dr. Sadachar. Many times the people ask that why I can't use this vaccine for the males above 14 years, like a 16-year or 17 who just missed the bus. Why is this difference? Why is it not licensed in India for males above 14 years?
Basically, HPV4, Gardasil has not done any studies in India for the
so can you use off-label, which means suppose, I mean, forget now you have HPV9 or HPV4 of serum, but say when these were not available, that was the question that, I mean, my cousin took it in the USA, but why can't I take it here? Okay, could you have taken off-label by taking written consent or something?
No, actually, as there will be already exposure after the age of 26 or 27 years, there is a possibility of exposure to the virus. So there is less benefit from that vaccine. So even if taking off-label will not of much use.
No, so there is no age limit for any of these vaccines till 45 years. I mean, that is true that as the age advances, the effectiveness will be lesser because of the exposure. But the exposure is still not, I mean, if you look at the Future 3 study in females, up to 45 years, between 25 to 45 years, the efficacy was 85%.
85.
As compared to 98 in younger women. So it's not that you can't give it to older women and older men. The question was, because the studies were not there, indication for males was not there. So like in past, whenever parents used to ask, I used to take written consent and give, because it's licensed by WHO, licensed by many other countries. So which means it's not licensed here. It doesn't mean it's contraindicated. When you use off-label, you have to take a written consent. All right, last question, Dr. Sanjay. You have this HPV4 vaccine in world for so many years. What has happened to countries which have used this as a national program? What are the impact data?
I think, sir, we'll just take 3 minutes to give you the impact of this HPV vaccine.
Please.
An excellent article I have gone through, which was published in IDSA 2016. Its impact and effectiveness of quadrivalent HPV, a symptomatic review of 10 years. Real world experience.
Correct.
More than 70 countries have introduced HPV, this quadrivalent HPV in their national immunization program. And almost 500 million doses have been given so far.
So that establishes safety too?
Safety and safety in across the world.
Correct.
And now we have started getting the benefits of that vaccine.
So like what benefits? What has happened in these countries different than before vaccination?
The biggest benefit, the first which they have seen within first 6 years, was significant reduction in the genital warts.
Correct.
Which has got a short incubation period which can be seen within.
Correct.
The
Perfect.
second was significant decrease in the high-risk genital intraepithelial lesions.
Correct.
As compared to an unvaccinated population.
Or a historical cohort.
Yeah. The third point, whether there will be a decrease in the number of cancer cases, it will take another 5 to 10 years, because if you see from the high-risk genital lesions, it takes about 20 to 30 years.
Correct.
So now the world is in that phase that in another 5 to 10 years, we'll get significant decrease in the number of cancer cases also. Because of the vaccine serotypes.
I think that is the biggest issue that has been racked by anti-vaxxers, that there is no data to suggest it prevents cervical cancer, because you cannot have a double randomized control trial for 30 years. So that's why WHO says that what it decreases precancerous, it is expected to decrease cancer in the future, because precancerous lesion is a necessary precursor of ultimate cancer patient.
And in most of the studies have come from Australia, then Sweden and America. And we should appreciate the Australians that they have going to achieve, because of the very high vaccine coverage, not a single case of HPV disease by 2025.
Correct.
I do not know whether they are going to have it, but then they are going towards this.
Correct. So it also has brought down the number of pap smear required, number of cervical treatment required, because the lesions don't happen in vaccinated couples. So correct. So I think the huge benefit. Let's move to the HPV-9. Dr. Digan, what is the efficacy data on HPV-9, which means for the remaining 5 serotypes? For the 4 common serotype, you would expect it to work as good as the HPV-4 of MSD.
Yeah. So basically, with this HPV-9 long-term data, we have seen that there was a study conducted by Susan et al. It was a randomized double-blind control study where they studied for both the safety and tolerability as well as immunogenicity of HPV.
Correct. In what age group and in which?
It was in the age group of 12 to 26 years age group, and total 924 female were
only
enrolled.
women. Females
Yeah,
are
they
women.
were enrolled for this vaccine.
Correct.
And they were previously vaccinated with quadrivalent HPV vaccine. And the randomization was done at the rate of 2 to 1. And the study group, they received 3 doses of HPV-9, and the control group, they received 3 doses of placebo, that is a saline. And then the schedule was followed same means 1, 2, and 6 months. And then samples were collected on day 1, 2 months of age, 2 months after the vaccination, and 7 months. And the titers were studied. And what the result they found, that at 4 weeks post the third dose, almost 98% of the subject who received the 9-valent HPV, they were seropositive for HPV serotypes 31, 33, 45, 52, 58. And there was a...
What about the efficacy?
Yeah, so there was a definitely marked elevation in the GMT titer also in for this HPV serotypes. So definitely this HPV-9 who is administered in patients with HPV-4 who has taken already...
No, I'm talking about HPV-naive women who have not received HPV-4. The pivotal trial which was done to study the effectiveness of HPV-naive subjects who were randomized to receive either HPV-9 or HPV-4.
Okay. Sorry. So this was again I mix up the answer. I mix up the condition with the vaccinating with HPV-9 in a patient who has already...
No. First,
Okay,
the vaccine would be licensed based on the pivotal trial in naive people.
Yeah. So again, this was a phase 3 trial of more than 10,000 people, women belonging to age group of 16 to 26 years. And it was again for the safety and effectiveness against the anogenital lesions, precancerous lesions, and the vaccine efficacy was found about 96.7%.
So similar to what was there with HPV-4, now with
HPV-4.
HPV-9 for the remaining 5 serotypes.
Right.
And for the HPV-4, it was the same between the 2 arms. Which means it worked as good as HPV-4, because HPV-4 anyway was given to the placebo. It was not a saline placebo.
Yes.
So very good. And this study has been long-term follow-up is done?
This is 10-year study.
Correct, fine. All right. What about adolescents, Dr. Sadachar? There was an age extension after studying it in the young women, the adolescents, boys and girls. I'm talking about HPV-9.
Definitely. The earlier there was a study conducted by the Merck company, manufacturer of HPV-4, and they mainly assess the initiation process. Meaning, earlier we initiate the vaccination process, the more is the effectiveness of the HPV disease prevention. And also there are other studies regarding the safety profile of Gardasil 4 in adolescents. And they have also showed that there are not much serious adverse effects seen, but the seen effects are mainly the skin rashes or syncopal attacks.
So what happened to the disease pattern? I mean, safety established very well, as Dr. Sanjay said, 500 million doses. There is no question about safety. Yes. What happened to those girls? They were not sexually naive. I mean, they were sexually not active. So you can't do double-blind randomized control trial. It's ethically not permitted. So when they were followed up, when they become sexually active automatically with the age, and then in the boys and girls, they didn't find a single case of either genital lesion or the high-grade cervical lesion, which means it was an effectiveness open label study. It was not an efficacy double-blind randomized control trial. But when they become naturally sexually active and followed up, they found that the vaccine worked as good as in the older women, and just with 2 doses. So that was the great advantage of this vaccination in adolescent. And HPV-9 also the same thing happened, that they had an age extension study done in naive adolescent and followed up for long term, and they looked at that there was not a single case of breakthrough disease happening. Sanjay, what about males and HPV-9 studies?
Yeah, there are a few studies which I can quote for the HPV-9 in males. The first study was published in 2015, journal Vaccine, and it was the safety and immunogenicity of HPV-9 in males.
Correct.
And the data which was collected from this was used to bridge the vaccine efficacy in the girls from 9 to 26.
Correct.
That is how the males were given, the recommendation were given to use this vaccine even in the boys from 9 to 26 years.
So it was an immunobridging study.
Immunobridging
between adolescents on one side and the younger women, for which you had an efficacy of 98%, as Dr. Digant Sastry says. So what did the study show?
The study said they have taken almost 1,000 heterosexual men and around 300 of the men who is having sex with men.
Correct.
And the comparator was the females in the same age group, and they were given 3 doses, 0 to 6.
Correct.
And surprisingly, the antibody titers in heterosexuals and MSM were non-inferior to this.
Correct.
Except one finding that MSM had low antibody titers throughout, but it was not statistically important.
Correct.
So they say it should be given in heterosexual males as well as in the men having the sex with men.
Correct. That means the presumption was that it was extrapolated that the efficacy would be as good as in the females for which HPV-9 has proven efficacy.
Similarly, which they have done it in Cervavac also. Similar type of immunobridging and all.
Perfect. Dr. Digant, you already touched upon this women who have received HPV-4 before and then received HPV-9. At what interval can you give? I mean, what interval was the HPV-9 given after the last dose of HPV-4 in that study?
Yeah, so basically, as sorry, I had mixed up this with the previous
Doesn't matter,
question,
it's okay.
But yeah, so again, one word, I will like to put a word of caution. The ACOG, that is the American Society of Gynecologists, they are not recommending routine HPV-9 administration in cases who have already received the full course of HPV-4.
Correct.
But
if
still,
the parents
still,
ask,
yeah,
no, I want better protection. I can afford.
So again, this this is very, very tricky in the sense that when should we offer this vaccine? But as we know, the age group here is for female, it is 9 to 26 years for the Gardasil 9. So forget about anyone who is coming after the age of 26 years, right? Now, if the patient is between 9 to 26 years and has received the HPV-4, that is Gardasil 4 full course, maybe the 2 dose or 3 doses, in that case, I haven't come across any specific time limit for repeating
in
the
the study
course.
that you quoted, the HPV-9 was given more than a year since the last dose of
Yes.
HPV-4.
Yeah.
But there was no upper age limit.
No
So
upper age.
obviously you could use it for as per the age indication in your country. If you use it above 26 in women or above 14 in males, the HPV-9 vaccine, it will be off-label,
Off-label.
not contraindicated. It is indicated till 45 years internationally. So you would take a written consent and not just give it just like that.
But
Sanjay, you wanted to
we
say
need
something?
Not
staying.
giving the HPV-9 after the HPV-4 has no scientific basis, but it is
No, no.
basically because
No one is saying don't give. He
No,
says we don't know
it is not
what
routinely
age.
recommended. It
even
is
I was reading the CDC guidelines.
Hmm.
The insurance people may not refund the money.
So it will be out of
Otherwise,
Yeah.
pocket.
a scientific reason why we should not.
Correct.
Yeah,
So
yeah, yeah.
Sanjay, what about now long-term study of HPV-9? We already said for 4 Nordic country 14 years
Yeah.
and for the elder women 10 years. For HPV-9,
We have 3 studies available. One is Latin
mm-hmm.
American study for 6 years and now it is 8 years.
Correct.
Another is an Scandinavian study.
Mm-hmm.
And the one which we have already seen with the long-term follow-up study of quadrivalent HPV.
That we said.
Similarly, there is an extension study for
Correct.
long-term follow-up study of HPV-9.
9 itself.
And
Okay.
this is now 8 year study. And
Correct.
it has shown that even at 8 years, the antibodies are persisting.
Correct.
And there is no need to give a booster even at 8 years. And
Absolutely.
secondly, they have seen 97.3% vaccine efficacy, effectiveness.
Effectiveness.
Persisting
Open
effectiveness,
label.
yeah, open label.
Yes.
In this population, and not a single case of penile intraepithelial lesion in boys
Breakthrough.
or breakthrough infection. So boys as well as the girls, they are showing highly protected if we use HPV-9 even for 8 years, and they are
Correct.
going to
Fine.
continue it for 14 years.
Correct. So last question on HPV-9, Dr. Sadachar. Again, now this HPV-9 has replaced HPV-4 in many countries abroad. And what has been the impact data? Like how much is reduction in the disease pattern, whether it is requirement of a specimen collection or coming positive for high grade, low grade lesion, etc.
The Yale University in US has conducted a systematic review of HPV vaccine effectiveness
Correct.
studies that included the analysis of effectiveness against vaccine type HPV infections by the age at vaccine initiation and or completion, whether they are completing the series or not. That
Correct.
also matters a lot regarding the effectiveness of protection. So 17 studies found that out of 21 studies, highest vaccine effectiveness in the young they are given at the youngest age group.
Correct.
Effective vaccine effectiveness estimates for younger adolescents ages 9 to 14 years range between 74 to 93%. And for 15 to, if it are given in 15 to 18 years, the protection was around 20 to around 85%. So the results demonstrate that the HPV vaccine is the most effective against HPV disease outcomes when given at younger ages, emphasizing the importance of on-time vaccination. There is one more study, sir, from Gardasil company itself, that MSD, that has done the 10-year long-term follow-up data they have taken. And that is a peer-reviewed in the Journal of Pediatrics for girls and boys who received 3-dose regime of Gardasil 9 at 9 to 15 years old. So this study was conducted from 2009 to 2021 across 13 countries and 5 continents. And the data showed sustained antibody response of HPV at 10 years and after 3 doses in boys and girls both. So
no, that's the long-term study. I'm saying once the country starts using these vaccines, what happens to the disease pattern? I mean, just to give you an example, a study done in Australia, they have seen that almost 98 to 100% decrease in cervical disease of any grade, high-grade lesions, vulvar vaginal grade lesions, or a need for biopsy and so on and so forth. So a very dramatic decrease in the HPV disease burden, even more than HPV-4 now because there are 5 additional serotypes. So obviously the impact will be even more than what Sanjay said before when he was talking about the long-term impact of the HPV-4 in the national program. Now let's turn our focus to the third vaccine, and I think that's an important vaccine because it's an Indian vaccine. It's a very cost-effective vaccine, but we should also scientifically deliberate as to how good this vaccine is. So, Dr. Sadachar, what's the difference between HPV4 from serum and HPV4 from MSD?
Sir, basically, serum HPV is same. That is,
Serotypes are the same.
6, 11, 16, and 18.
Only the age indications.
Yeah, only thing is, it is made in India, our own country, and recommended dosage depends on the age of the patient.
Correct.
So, in Sarvavac, that is licensed for both boys and girls, and that is in 9 to 26 years. It is being licensed.
License, okay.
Yeah, and it is not licensed beyond 26 years.
Correct.
And for boys and girls between 9 to 14 years, 2-dose regime is there with 6 months interval. And for 15 years onwards up to 26 years, there are 3 doses regime. That is
that's the difference.
Yeah, there's a difference.
Correct. So I think again, when it comes to 9 to 14 years for Sarvavac, you have official recommendation only 2 doses license, whereas for Gardasil 9 it is 3 doses as per licensing, but ACBAP said you can use 2 doses, and for Gardasil 4 it is 2 doses even for licensing. Above 14 years, HPV 9 is 3 doses. Also, Sarvavac is 3 doses. Also, HPV4 was 3 doses, except that in males, HPV4 was not recommended in our country. So, I think this confusing statement we'll have to keep on making again and again. And in spite of that, I'm sure all of us will get some WhatsApp tomorrow. Sir, please clarify what you said. All right, let's move. Dr. Sanjay, how was Sarvavac licensed? There's no efficacy data. So, how was it licensed?
Sir, this study was, because it is mandatory to publish a study.
Correct.
And the study was published in Lancet 2023, and the same was submitted to the DCGI for the approval. So what they have done, they have formed the 3 groups.
Correct.
9 to 14 boys and girls.
Correct.
And 16 to 26, 15 to 26 boys and girls.
Correct.
And comparator was the quadrivalent HPV by MSD in all these groups. The problem with this study,
only 16 to 24 women.
Correct. The problem with this study that
so why were boys not compared with HPV4 of boys of MSD?
Because it is not recommended to be used in India.
For you.
So that was the limitation.
Correct.
But the good part is,
so
safety and immunogenicity, they have established it is non-inferiority to the antibody titers from the females from 16 to 26 years.
Correct.
And once they have established the non-inferiority, similarly what I had discussed before, this data was used to breach for the vaccine efficacy and was recommended.
Correct. Now, so like the HPV9 in males was immunobridged to HPV9 in females with an efficacy data. Same way here HPV4 of serum was immunobridged to the HPV4 of MSD in women where efficacy established, and you show non-inferiority and immunogenicity, you actually say the vaccine is going to work as good. I mean, that in essence was the study design, correct?
Sir, very interesting fact of the study. This study has said it is non-inferior in the age group of 9 to 14 years only.
Correct.
And recommendation is for 9 to 26 years.
26.
Correct.
Then I asked, what about the second part? Because in the study, the second part is there. They said they have already submitted the data to the DCGI after 8 months of the study.
Correct.
And on the basis of that, they have given the permission.
Correct.
However, the same cohort will be continued to be followed for next 36 months.
Correct. To see for effectiveness.
And then the study will be published in the Lancet for recommendation from 9 to 26 years, and what is the vaccine efficacy as far as the genital warts or the other things.
So I think some of you might have seen the data on file, though it's not published. I'm sure Dr. Digant would have seen as a convener, and the data on file for 14 to 26 years men and women compared to 14 to 26 women of MSD4 vaccine looked very similar data. So they were found to be non-inferior. Based on that, they have got licensing for up to 26 years. Now the question, Dr. Digant, that HPV4 of serum, Sarvavac, is licensed based on only immunological non-inferiority and of course safety. So is there any effectiveness data, though there is no double-blind randomized efficacy trial, is there any effectiveness data with this vaccine?
Actually, I had asked for that, but I could not get means even in the literature also I could not search. But what has been means in the study which Dr. Sanjay mentioned in the published in the Lancet 2023, there is almost 100% seroconversion was reported for all the 4 serotypes of the vaccine, and the GMT titer was more than 1,000 times to the required GMT titer for the vaccine to consider the vaccine as a seroconversion. So, from considering these two things, I think we can extrapolate it that it is effective for preventing the both cervical cancer
In
as
fact,
well as.
I am privy to the data on file of the serum's vaccine, and they have followed up this cohort at 24 months. And they found that neither in the Cervavac group nor in the Gardasil group, there was enough number of cases which were different. So, like for 18, there were 6 incident cases in Cervavac group versus 3 in Gardasil group. And for 18, for 18 there were 6 and 3, whereas 16 there were 0 cases. Again for 6 there was 0 versus 2, and for 11 there was 1 versus 0. So it means that at 24 months the effectiveness looks as good as with the what would expect based on the non-inferiority criteria. So I'm sure 36 months and another 48 months data, once it matures from serum and when it's published and available for review, we'll be interested. But good to know that at least initial data is suggestive that it's going to be a effective vaccine. All right, we turn to the last part of discussion as we are running out of time.
24 months data is called as vaccine efficacy or the
effectiveness between Gardasil and Cervavac. Those children, those adults who are given the vaccine, they were followed up for what type of lesion they are developing over the next 24 months. But that's a very, what do you call, a very raw data and very first type of data, but very interesting and very encouraging that it's going to work as good. All right, let's discuss male. Dr. Sadachar, why immunize males?
Definitely. Immunization of males is as important as females. Basically, it gives protection to their partners and to improve the population level of HPV infection control and directly prevent HPV-related disease in males, such as anogenital warts, penile cancer, anogenital cancers. There is definite need to immunize males. Protection of sexual partners are very important. Another reason to immunize males being there is no test for HPV infection in males as pap smear in females.
Correct. So there's no screening program.
Yeah, and the risk of getting HPV-related cancer increases with age. So as today's men live longer, then longevity has increased. So there is an increased risk of this type of genital cancers also. Incidence of genital cancers in males are also increased. So there is a need to.
Correct. So to me, the males, the males, the prevalence of HPV remains the same throughout their life, unlike in female where it goes up and down. Second, they don't mount good immune response as females mount. And that's why reinfections are 2 to 6 times more common than in the females. And if you are protected male, the female will be protected and vice versa. So it is good to protect both men and women. Is there any, Dr. Sanjay Marathi, if you, people ask, that for males, when the cervical cancer is not there and the difference of 18% more serotype coverage because of 5 additional serotype is not there for males, so what's the real benefit of HPV-9 over HPV-4 for men or for boys? Is there really much difference?
Yeah, I will start with the statement that in the females the incremental value of HPV-9 over the HPV-4 is almost 20%.
Correct.
You can say 15 to 20%.
Correct.
Whereas in the boys, it was said to be around 5 to 6% incremental value, additional protection. So when I was going through the disease burden of HPV-related cancers attributed to 9 HPV types, the 5 extra serotypes are giving you some protection against the anal cancers, the penile cancers. Most important is the oropharyngeal cancers and oral cavity cancer. So the study has said the 5 additional serotypes in the male will give you 8% additional protection over 16 to 18 for anal cancers, 9% in penile cancers, in oropharyngeal cancers 4%, oral cancers, oral cavity cancers 8%, and larynx around 1.6%. So now in the American study, though the number of cases are less, they have seen HPV contributing significantly into the oropharyngeal cancers, especially in the posterior part of the tongue and the upper part of the pharynx.
Correct.
So now they are getting maximum cases in this area. So apart from say about 4 to 5% of the incremental value of HPV9, I think the importance is getting shifted to the oropharyngeal cancers.
And also, if the male is protected against 9 serotype, the
He will
female
not
partner, if
infect.
she's not vaccinated, she
Automatically
will also get
safe.
protected against the 9 serotype. I mean, where the benefit is more, as you said. Okay.
I think
Now the last part, reduced dose. Everybody discussing. So WHO recently said that one dose is enough up to 20 years, though off-label, where two are recommended, and two are enough for about 20 years, up to 45 years of age, though off-label, because three are recommended. So Digant bhai, I think what is the study, Indian study, which actually opened this Pandora's box about reduced dose by Dr. Basu's group?
Yeah.
You can
So
summarize it to 2 minutes because we don't have much time now.
So Dr. Basu group, they had a nearly this 10 years follow-up cohort of about 17,000 women who had received the quadrivalent HPV
Correct.
between 2007 and 2008, when
Correct.
they were of the age of between 10 to 18 years of age.
Correct.
And what they
And
look
how many
for
doses they had received?
There were groups who had received only one dose. There were group who had received 2 doses and 3 doses.
Correct.
So what they saw that the group who had received only one dose, still they had a equal protection against the two high oncogenic serotypes, that is HPV 16 and 18. And
as good as 2 and 3 doses.
Yeah, as good as 2 and 3 dose. And the efficacy was nearly 95%. So these led to several such studies in Costa Rica, Kenya, Tanzania, and other parts of the country. And I think even WHO, as you said, even on the WHO website also they have this, that it can be used as a off-label.
Right. So Sanjay, Dr. Digant mentioned about the Kenyan study. That's not a Scanshi study. What is this Kenyan study? Basu's was an observation study. Kenya did actually a randomized trial. What was it?
What they have done the study in Kenya, as there is very high disease burden in the Kenya. Even the prevalence is 6 times more than in Europe patients. So what they have done, they have taken almost 2,000 odd participants, and they have divided into three. 1/3 was given the bivalent cervarix.
Correct.
1/3 was given nonavalent.
Correct.
And the third was given meningococcal as a comparator.
Correct.
And this patient, the aim was different. The aim of the study was whether there is in the decrease in the incidence of HPV infection.
Correct.
Rather than the lesions, and subsequently they were followed it for the lesions also.
Correct.
And to their great surprise, significant number, almost to the tune that one dose was giving the same protection, and there was significant number, almost no case of cervical HPV
lesions
identified in this population.
Correct. And how long was the follow-up?
36 months was this, and now it will be continued, because now there are 4 different studies with Dr. Digant Bhai was saying.
Correct.
It will be followed as a long-term follow-up or a single dose.
Correct. And Dr. Sadacha, the Costa Rica study that Dr. Digant mentioned, if you can briefly mention what was the Costa Rica study?
In Costa Rica study, they gave only one dose of bivalent HPV vaccine. And that induced the stabilizing antibody titers for a longer time. I mean, they provided the protection against HPV 16 and 18 infections for more than 11 years.
Correct.
So, that antibody titer elicited by one dose was even 9 times higher than that has been levels is by natural infection.
Correct.
So even one dose was efficient to protect HPV disease.
So I think the long-term data from Costa Rica on immunogenicity, can she study showing at least 3 years effectiveness data with a double randomized control trial and a 10-year follow-up by Indian study by Dr. Basu, which was the default study, but to great extent helped that one dose is enough. And I think that is the reason why a lot of recommendation are there. In fact, UK, gives only one dose of HPV-9 from 9 to 25 years of age, not even 20, 25 years. And after 25 years, they give 2 doses 6 months apart. So people have already started using this reduced dose in their country. So that brings me to a rapid fire to Dr. Digant, because this has to something to do with IAP, ACVIP. So 2 doses of HPV-9 in 9 to 14 years old. Recommended already.
Yeah,
No
so
issues now.
there is
Consensus. All
consensus.
right.
Same,
Use of HPV in males beyond 16 years. You think
So I
IAP will
think
take
we
a
have partly discussed it that you can use it up in the male up to 14 years only by as per the
licensing
BCGI license, but you can use it off label, or otherwise if the parents definitely wants the protection, then you can offer the quadrivalent HPV, that is Cervavac, for the
No, I'm
male.
talking about HPV-9.
Yeah, so you cannot use it. You can use it as a off label only.
Yeah, but off-label IAP ACVIP is going to recommend off-label use.
No. We haven't discussed about this thing.
I think you should discuss this, because now let's say one dose is enough till 25 years. Why deny a 20-year-old or a 21-year-old an HPV-9 if he wants to take it? I mean, I would give it with a written consent, because there is international recommendation to use HPV-9 till 45 years of age. But if ACVIP also endorses it, even with written consent, I think it will make even more sense. So I think I urge the IAP-ACVIP in the next meeting to discuss this.
Yeah, sure,
Then
sir.
same way HPV-9 in females beyond 26 years.
Yeah, so again,
Same thing, till 45
same
years.
thing, yeah.
So you'll have
And
to
again,
probably
the reduced, I think
and reduce dose, yes.
reduced dose again, as of now, the recommendation is not, even the WHO is not officially telling as a use, or as a off-label use only they are recommending. So in a practice with a prior consent and informed consent, one can use, but not
No,
as
so that if it comes in the ACVIP recommendation,
then
we
yeah,
recommend to
then
use as off-label because of international recommendation and WHO and countries like UK using it. But please do take a written consent so that parents understand the implication. I think that will be a great help. Then it will not be looked that you are giving this vaccine only for profit, that you are actually giving it to help the community.
Absolutely,
So
absolutely.
I think maybe next our
Yeah, it is
purple book.
yeah. So actually, just the next recommendations, we are planning to have a evidence-based grading system also.
Achha. So when is it going to come, the next recommendation?
The next recommendation, I think the purple book will be released in next 1 or 1.5 month. But then the next to that, so in this 2025, we are introducing the grading evidence grading system also.
Perfect. And the last, I think, a lot of talk about safety. So, Dr. Sadachar, I mean, we already said that more than 500 million doses of HPV-4 and another 100, 200 million doses of other vaccines used. It is found to be very safe. You have anything to add to that?
Yes, basically, lack of meaning, there is a lot of anxiety regarding the safety in parents as well as the adolescents.
Correct.
So there is a vaccine denial because of that, and there is a media that makes hype. There are some wrongly labeled scenarios which were wrongly hyped. So this vaccine is absolutely safe based on scientific evidence and safety data. The HPV vaccines are just local site pain, induration, meaning redness, soreness is there. In some
so no red flag.
No red flag. Syncope.
Except adolescents, give them in lying down position or sitting position and not in standing position.
After give a 15 minutes gap so that the patient, the child should lie down or sit at one place, and then that is the main precaution in adolescents.
Even the so-called venous thromboembolism episodes, which were found to be a little more, they were all dispelled, and they were probably statistically not significant. Dr. Sanjay, in the past, there was an uproar in parliament when HPV-2 and HPV-4 of GSK and MSD were used in a campaign mode in Gujarat and in Andhra Pradesh, and some deaths happened. Just 2 minutes, you can elaborate on that and what happened after that.
Unfortunately, the HPV vaccination was in the limelight for the side effects rather than the effects of the HPV. And fortunately, in none of the side effects mentioned, there was a causal correlation established.
Correct.
Now the take-home message for all of us that it's a very safe vaccine, and the side effect, the syncope was described so much, and the death because of the syncope has nothing to do with this.
Correct.
And almost 783 episodes of syncope were reported in this, and ultimately they have to stop the vaccination program in this.
Correct.
Another very silly correlation they tried to establish with the parts like postural orthostatic tachycardia syndrome or
Correct.
CRPS, that is chronic recurrent pain syndrome with violent leg. They even got to the extent that saying that there is a primary ovarian failure with the HPV.
Correct.
They tried to correlate this with the autism, adult autism, and a
Correct.
GB syndrome.
And
GB
the
syndrome.
clock that
Yes.
is running even today on website, how many
Yeah.
deaths have happened?
Correct. That silly video, you can see some doctor from another pathy
Yeah.
saying that this is an useless vaccine,
Oh
and they have seen
God.
more cases of cancers because the vaccine was given. And
Correct.
I must be thankful, rather, we should be thankful to Dr. Nitin Shah for giving an excellent explanation to on that video. And I
Rebuttal.
must have circulated it to thousands of people
Yeah.
in the social
Correct.
media.
I know, I know, I know.
Unfortunately, they believe in that video more than the scientific explanation by the doctors.
Correct. So I will just add to say that when the bivalent and the quadrivalent vaccine of GSK and MSD was used in Gujarat and Andhra Pradesh, and the deaths have happened on those tribal girls, the real problem was the consent. It was not taken from parents. It was taken from the rector of that hostel. But the blowout was of the death that happened. Now, what were the deaths? One was drowning,
Suicide.
one was
One was
snake bite,
suicide.
one was
Ah.
dengue, two was suicide. And they have nothing to do with HPV. Then a technical committee of ICMR said exonerated. Then there was a parliamentary committee on the top of the technical committee which also exonerated. And so many fasts happened, and ultimately the vaccine continued. They were wanting to ban it. And I remember there was one case of a girl in UK, adolescent girl being given vaccine in the school clinic program, and she was found dead after 2 days. The vaccination program was stopped in UK that time, and there was an uproar about the safety. A post-mortem was done. Actually, she had a lymphoma, and she had choked because of lymphoma, and not so she was actually a contraindication for the vaccine in that sense. But of course, she didn't have much symptom before this, so they couldn't diagnose, and the vaccination started again. So these small incidents which are blown up, like the myocarditis following Pfizer's COVID vaccine,
COVID
or
vaccine.
venous thromboembolism, or some myocardial infarct following the Chadox vaccine, and so on and so forth. We as humans are very ungrateful.
Yeah.
We want to reap the benefit, and then at the same time still blame what actually saved your life. So I think with that I will end today's session on the HPV vaccine. I would really like to thank Dr. Digan for sparing his time as the convener of the ACVIP, and of course as an expert and a good friend of mine, for throwing light on various aspects of HPV. Dr. Sadachar and Dr. Sanjay Marathe, both our own colleagues from Maharashtra, for doing an excellent deliberation on the HPV vaccine. And I'm sure all of you would have been now convinced that these vaccines are extremely safe, they are highly efficacious, even with one dose or two doses, which means reduced dose, and a very long-term data, 14 years and above for effectiveness, and 10 and 14 years for the immunogenicity. I mean, what more can you ask for? And now that you also have an extremely cost-effective vaccine from India, there is no reason why we should not be promoting HPV vaccine with vigor. And in the last budget, there was a provision made for the HPV vaccine to be included in the national program.
Yes,
Though still it's not started, but I'm sure it will start soon. There were some states like Punjab and Manipur, or I'm not very sure, one or two states in the northeast which have started this program. Of course, that has not continued, but sooner or later this vaccine will become part of the national program, and I'll be the most happy person, because I always say that one vaccine which I feel I want to fight for is HPV, because it's not for men directly, it's for more the women who are the silent workers in our home. They are our mothers, they are our sisters, they are our daughters. And if we don't stand for them, who will stand for them? With that, I would like to thank the MAHAAP for giving all of us this wonderful opportunity, and hand over mic back to the organizers. Thank you.
Thank you so much, sir. Thank you for such an interactive and informative session, and also simplifying various types of HPV vaccine. So can we take one or two questions from the question box, sir?
Yes, please go ahead.
Yes, sir. So the first question, if a 15-year-old has taken first dose 3 years back and has lost to follow-up,
Correct.
so when she comes back, should we give 2 more doses or just one single dose?
2 more doses, because she's now crossed 14 years.
Okay, sir. Another question,
But
is
those two
vaccine
doses will
against...
be 4 months apart.
Yes, sir.
Yeah.
Is vaccine against all serotypes necessary in boys to prevent benign cancer?
Just repeat the question.
Vaccine against all
Vaccine
serotypes.
against all serotypes,
When we HPV
including
9.
all serotypes.
Yeah.
Yes,
So Sanjay is actually
Yes.
not licensed. I mean, there's no licensing for penile cancer.
Penile
It's
cancer.
only for anal
Only-
and
No,
head face
I
neck
said
cancer in men.
the incremental value is around 5% over the
Correct.
HPV4, but
Hmm.
now the focus is more on the oropharyngeal cancers.
Correct.
So it is definitely, and what very rightly Dr. Nitin Shah said, that if I give nonavalent vaccine to a male, the indirect benefit goes to the female, that she
Female.
will not be being exposed. So this is the biggest advantage I personally.
Okay. The third
You
question.
can say like it is like a herd immunity.
Herd immunity. Okay.
Third question, does the
Yes.
vaccine prevent cancer in a person already infected with HPV?
Yeah, I think this this answer
Yes.
question has been already answered in the discussion, that it will prevent against the serotypes which are the patient has, means the person has not been infected with the serotypes. Against that, definitely it will protect, as well as it will protect against the reinfection also.
Correct.
Sir, one
So-
more point to this question. Now I was reading one article, the HPV trial from Japan as a therapeutic HPV.
Correct.
And so I do
Okay.
not know, after say couple of years, you will have a therapeutic HPV vaccine.
Maybe.
They have seen 50% reduction from the CIN3 to normal to CIN1. That
Correct.
was
Perfect.
50%. But then the
Perfect.
total number were just 18.
Correct.
So we
So
cannot
large
come to
studies
any
are
conclusion.
Yeah.
large studies are cohort are needed.
Next
So
question.
that's all, sir. That's all, sir.
That's all.
Rest of the
Okay,
questions
fine.
have been answered. That brings us
Please-
to the end of the session.
Please
I request
conclude.
Dr. Tanushri Mukherjee ma'am to kindly deliver vote of thanks.
Excuse me,
Thank
sir.
you.
Sir, one more doubt, sir.
Yes.
Sir,
Go ahead.
sir, one of my, patients mother, she is nearing 45 years. She has not vaccinated against HPV, sir.
Mhm.
If she takes a full course now, will it be useful for her?
Yeah, till 45 is the indication. So when you say 45 years, it will be 45 years and 364 days. 45 and
44.
365 days, she will become 46 years, then you can't give this vaccine. But if you give it, it will be off-label. In fact, there is nowhere in the world they say above 45 years to give the vaccine. But there will be some benefit of this vaccine even at that age.
So is HPV9 is the best, sir, for this child?
If someone can afford,
It
yes.
is
If
not.
someone can't afford, HPV4 is good enough at that age.
So again, if somebody is going for a off-label use, then it is better to use a more valent vaccine than less valent.
Correct.
Okay, thank you, sir. Thank you.
Yeah,
Over
Dhanushi.
to you,
Yeah.
Tanushri ma'am.
Thank you so much for the wonderful session, sir. And it's on behalf of Maha AP. So I think it's an excellent discussion, and we can see lots of messages on the chat group. So no vaccine CME is complete without Nitin sir. And
Absolutely.
and sir, thank you so much for being there and patiently answering. It's always so nice to hear from you.
Thank you.
And we
So
will.
before you propose the vote of thanks, the next session will be on the 4th of April,
Okay,
same
sir.
9 to 10:30, and the topic is newer PCVs.
Wow.
You have now 10 valent, 14 valent, and some new 13 valent
13
vaccine.
valent.
What does it all about? What is the data? How do you choose one? It's a lot of confusion in the minds of people. So we will discuss newer PCVs on 4th of April, same 9 to 10:30.
Sure, sir. Sure.
Thank you.
And sir, like we discussed everything about the schedule, the indication, the controversial but very important off-level uses, the long-term data, as well as the importance in the males as well. And I would really like to thank our esteemed panelists today, the Dr. Digant Shastri sir, Dr. Sanjay Marathe sir, and Dr. Sadasar Ujjalgan sir. And our Maha IAP team, the president, our president, Dr. Sanjay Pakmugre sir, our secretary, Dr. Amol Pawar sir, our convener, Dr. Sanjay Deshmukh sir, and our scientific chairman, Dr. Minat Sheikh sir. And I would like to appreciate the effort done by the technical team for this seamless CME. And thank you all delegate for being there. Thank you. Thank you so much.
Thank you. Good night,
Thank you, sir.
everyone.
Thank you. Good
Bye-bye.
night, sir.
Everyone.
Good night. Good night, sir.
Excellent
Thank you.
session.
Thank you. Good night.